We will now move on to the third presentation by Bruno Pauly. Bruno, we're in your hands. Over to you.
Oh, good morning. We have load shedding, so if you don't mind, I think it's better to not switch on the camera. Otherwise, I will have the same technical problems as the previous speaker. I'll try to share the screen. So I'm a specialist medical officer at Bara. I'm working in the endocrine space. Can you see my screen? I'm not quite sure because...
Yes, we can.
Oh, perfect. Okay. So I'll go into presentation mode. I have COVID at the moment, so my voice is a little bit croaky, and if I have a coughing fit in between, just forgive me. So thanks for organizing the conference and for inviting me to speak, and for Landa to kind of like get the discussion started. Bara is the third largest hospital in the world by beds, and Bara has got a very proud history of defending the rights of healthcare to the poor, especially under apartheid. So Bara is my home, and even though I'm always complaining and grumbling and mumbling, I'm quite proud of working at a tertiary hospital that provides excellent services in an environment of restricted financial resources. And Bara traditionally does not deny healthcare services to anybody who knocks on our door. The only thing is that I learned over the last 2 years that that is only true if you are cisgender. So the Bara Transgender Clinic, as it was then known, was started by Professor Shires around 2014, when he developed a special interest in the field. So very similar to what Madeleine alluded to earlier, Professor Shires, he comes from a very traditional school where his thinking centered mainly around the belief that gender-affirming hormone treatment should be provided at a specialist level. And I think that comes very much from the historical idea that variance of sexual differentiation was always an endocrine domain. After his retirement in 2020, I took over the responsibility for the clinic and the medical care of the patients, and I work under the guidance of Dr. Banna, who is the head of the department. Like very similar to what Landa and Madeleine already pointed out, I personally subscribe to the idea that services should be provided more at a primary healthcare level, but with the adequate support of specialists and adequate training and sufficient financial support, which is not always the case. And I see it as not being much different from management of other chronic diseases like diabetes mellitus. But that also, just to add here, is a big problem. I'm a diabetologist before I started the gender affirmation clinic. And we see the same problem that we also see with transferring some of the gender affirmation services to the local clinic. Nobody actually wants it. It's not wanted by the primary healthcare sector. It's not wanted by the secondary healthcare service. And it's also not wanted by the patients. And that's not only our, let's say, gender diverse persons that we look after, but it's in general. Our thyroid patients, our diabetic patients, they do not want to be down referred to the primary healthcare level because they feel that they get a better care at a tertiary healthcare center. And I have noticed that our gender diverse patients that we see, they have got the same belief in that. So in the following presentation, I will highlight the current situation at Bara. Just remember, it's my private view and it doesn't represent the official position of the hospital management, the Department of Medicine or the Department of Health. If it was for them, I should probably not speak at all. I'm a big fan of the music of Enrico Morricone, just to lighten it up a little bit. And I use the old Western theme to help illustrate my points. The Good, the Bad, and the Ugly, that's what I've called it, was directed by Sergio Leone. He was an Italian, and this is the movie that is very macho, but that I grew up with. And I will start with the good first, the services that we have at Hani Baragwanath Hospital. So although hospital management has restricted the number of gender diverse patients to 60, we currently care for 78 patients. That is a very low number if you hear that there's nearly 200,000 people who would actually require the access to healthcare. Of those, roughly 2/3, they transition from male to female. And to put this into context, also to go with peer, the gender affirmation clinic is actually very small. In our department, we look after about 6,000 patients living with type 2 diabetes, about 850 patients with type 1 diabetes, and about 900 endocrine patients. So endocrine is already overwhelmed with patients, and we're trying to down refer, but that is a little bit of an issue. So when I took over the clinic, patients received Premarin only, and stock supply was limited to about 2 weeks. So every 2 weeks, patients had to come and get more supply. We now provide Estrofem, and most transgender females have no major stock issues. And depending on stock availability, we offer either Endokur or Aldacton as a blocker. A few patients receive injectable estradiol Valoret, but that is scripted for, and they have to pay for that privately. That's probably why the number is quite low at our clinic still. All our transgender men, they receive Nebido for free. There is no formal services at any of the other 2 tertiary hospitals, and I don't think there's any service at the secondary hospitals. There have been attempts to start services at Soweto Clinic, but they seem to run into problems with high turnover of doctors and restricted hormone supply. So how do we see our roles? We see our role in the provision of basic counseling and education, gender-affirming hormone therapy, monitoring, and the coordination of services. So we, for example, do the letters to Home Affairs, and we write referrals to other specialists. I'm currently auditing safety aspects with regards to hormone treatment, because that was always one of the reasons why people don't want to give this to the primary healthcare sector. But so far, I've not come across any major adverse medical event over the last 2 years. Psychological services at Bara, they are quite good. So gender diverse individuals, as we already heard, they are a high-risk population for mental health problems. They are also exposed to regular harassment and discrimination, and that contributes to high rates of stress. And so this group is significantly more likely to experience poor health outcomes. Historically, the Department of Psychiatry was the first Bara department to include gender diversity programs in the form of individual sessions and group support. They did so well before Professor Chai started the transgender clinic, and I think they were the initiation factor. This was probably due to the then requirements by international guidelines like WPATH, where a psychological report had to precede any other intervention. So although the group sessions have fallen away, the individual support remains excellent and a cornerstone for our patient support. And I'm very jealous of Rutendo is here, I see, from WITS RHI. They've got a very good setup, and we have not been able to reach that, but our psychological services are quite good. So surgical services, on that side, we have very limited services compared to international standards and what should be provided. And I think that is a problem that we have in South Africa, not only in the public, but also in the private sector. A major issue of contention has always been if these are essential health services or merely cosmetic surgery, which falls way down in the hierarchy of needs or even outside the scope of services that can be argued for using human rights or something like that. So what's offered? Our mastectomies are done at the breast clinic, reluctantly, and maybe understandably so, because for years the department has been underfunded, and the head of department of the breast surgery resists to add more burden to the already unbearable workload. The situation currently is that there is a waiting list of over 200 patients, and I'm aware of 3 mastectomies that were done in 2022. So the other thing is that transgender men frequently report that they get a date for surgery, but then it is canceled due to other priorities. Breast augmentation is offered for free, but patients must pay for the implants at the current price of about 9,000–10,000 rand. And I'm aware of only 4 patients over all these years who had the procedure, but they seem to be very happy with the results. Sexual and reproductive healthcare at BARA is largely focused on maternal and other reproductive healthcare services. I think we have around 25,000 deliveries a year per BARA. So that is where the focus of the department lies. So that results in a narrow focus on heterosexual cisgender women and neglects the needs for gender diverse populations, including transgender women. So theoretically, the department offers hysterectomies, women's health checks, including cervical and HPV screening, but they don't offer a safe space. And that is a major reason for transgender women to stay away. I'm aware of only 3 transgender women who had a hysterectomy over all these years. We are currently in negotiations with the department to create a safe space where transgender women feel comfortable, but that is a long road. Urology services, we kind of had an agreement that 1 patient per month can be booked for orchidectomy. I'm aware of 2 procedures that they did so far, and there is no indication that any other type of gender-affirming surgery will be offered in the future. So what are the barriers, the bad? As I mentioned before, in the medical services, we are severely restricted to 60 patients, even though we sneaked in 78. And the waiting list to attend our clinic has grown to 108 persons, but there is a very high number we are not even aware of. They may not have started their transition journey yet, they may not know about our services, or they may attend WITS RHI. The number of 200 trans men awaiting mastectomy is an indication that we don't really know what is going on in the community. Where do they live? Where did it come from? What are their needs? On the surgical side, the heads of general surgery, urology, and plastic surgery, they are not really interested in a meaningful discussion on how to collaborate or improve gender-affirming surgical services. Restricted financial resources, emergencies, COVID backlog, they're all quoted to defend the inertia and the status quo. But you can see on the slides that some of the responses that our patients get from the department. So patients experience an atmosphere of stigma, lack of understanding, and absence of empathy. There's a lot of work that we have to do in that area, but unfortunately, they're not open to it. So it's more a matter of, if I have to, then that of providing a valuable service to a part of a community. As for now, there's no vision to offer services in a safe space, and our request to organize a combined multidisciplinary team has largely been ignored. And there's no interest in training for or offering constructive gender affirming surgery. There is nothing. So what's the future, the ugly part? We already discussed some of the general barriers, and Landa alluded to it quite nicely, to nearly every aspect of the lives of the gender diverse community. And these are not different to Soweto. We have heard and we will hear a lot about discussion papers describing the problems and suggesting possible solutions. There will be talk about excellent laws and policies, but in the end, it all comes down to a failure of implementation. And I sometimes ask myself if our society is actually ready for all this. So in the past 2 years, I learned that nothing will change in a climate of hostility, passive resistance, and lip service. So if a fairy came to offer me some wishes, this is what I would ask for. And that is very much what I think some people mentioned already this morning. So I would ask for a management that shows leadership instead of hiding behind directives, mandates, resource allocation, backlogs, and so on. I would ask for a safe space where we can offer healthcare without the fear of stigma and prejudice. I would ask for a multidisciplinary team. It doesn't matter where it is based, if it's in a primary healthcare or in a tertiary healthcare sector, but it should be multidisciplinary, and ideally it should include participation of the gender diverse community. I would ask to beef up institutional capacity. Again, it doesn't matter which level it is, but we need more capacity, and it needs to be backed up with policies, and it needs to be backed up with appropriated resources. I personally would agree with Madeleine and Landa that trans healthcare should be based at the level of primary healthcare. I don't think it belongs to specialists, but they should have appropriate training, they should have resources, and they should be supported by specialists if necessary. So in my opinion, trans health, including gender-affirming hormone treatment, is no different from treating a patient with a chronic condition like diabetes or prescribing HRT to cis women. So the last point that I want to mention is that I disagree a little bit with Landa here, but I would like to ask the advocacy groups to stop talking and do more. We need active measures forcing the government to fulfill their human rights and obligation. I experienced too often in the last 2 years that everything I try to do is actually blocked by some excuse of higher levels not making the right decisions and so on and so on. I think that we know exactly that things are not right, and we also know what needs to be done. But we now need is like more activism. And I often ask myself, where are the lawyers' letters and why is nobody toying? So that is the end of my rant. Thank you very much. Let me just see.
Thank you so much, Bruno.
Hope everyone is still there. Yeah.
We're still here.
Okay.
Thank you so much for that very detailed and very sobering, presentation. I'm old enough to also understand your metaphor of the good, the bad, and the ugly. So, so over to the audience. Questions, reflections. Kevin, go for it.
Thanks, Bruno. I can maybe even video. There we go. Cool. Yeah, thanks, Bruno. That was a fantastic talk, and it highlights the challenges that I think we all have in the state sector. So a couple of suggestions I just wanted to add. Firstly, don't underestimate the effectiveness of complaints from the patient-client population. It is incredibly motivating for management at least. So encourage all your patients to complain to management about the lack of service. The second thing I want to say is that we need to get you some support, because the only reason that the Groote unit is doing so well is because we've got a lot of very dedicated and able colleagues working together. And it helps to have the clinician community behind you as well. So that's something that I think we also need to try and focus on. And I'm well aware of the surgeons' bailout of saying, well, we've got too much other work to do. But we could certainly make improvements. So yeah, I just wanted to add those things into the mix. Thanks.
Look, the problem is a little bit, that was my last jab to advocacy or activism, is that, yes, I ask my patients, all the 108 patients on a waiting list, they get a standard reply. I'm sorry, we can't take you. I'm sorry, the management doesn't accept any new patients. Go to the 8th floor, speak to people, start a complaint. We also ask them to write an email. We give them the email addresses. We give them the names. They're not doing it. It's not the patients do not write anything, not even an email of complaint. When I speak to management that these services are needed, they say, no, it's not needed. Nobody comes to us to ask for this management. The surgical head, he says, look, this is not my job to fight for the rights of certain specific small groups, but I fight for the general health, general population, all these things. And that's what you hear. And that's where I'm a little bit disappointed by the, let's say, the space that there is, for example, lots of activism done from my side. It is important, not that I say that's not important. It goes a lot about legal status and IDs and all these things, but access to healthcare is actually not fought for. I have not heard that a letter by any of the advocacy groups has been written to Barra management to say, look, these are rights, these are healthcare services that should be provided to patients, even if there are only about 300 maybe or 400 patients compared to 6,000 or 7,000 diabetic patients that we care for. The other thing is Landa mentioned that there is a lot of talk behind the scenes in terms of like regulations and discussion papers, but nobody knows about it. Like my management, definitely my superintendent, he doesn't know about these things. My CEO at Barra doesn't want to know about directives. The Department of Health doesn't know about directives or policy papers. They are just hiding behind, I don't know what. It's just, nothing is happening. Not in 2 years, you know. And I know the same problem is in private for the surgical sector. In private, you also don't get surgery. It's not that it's a public problem only. Like surgery is just an issue. That's not even like the primary healthcare sector when it comes to gender affirmation hormone therapy.
So
Thanks.
if I could just jump in there quickly, Ron, with one other thing that I did think which may be helpful. Many years ago when we had the conference in Hout Bay, one of the points that came up, which I think is quite powerful, Bruno, is to mention that if management and policymakers are looking at effectiveness of implementation, the transgender community is probably the most marginalized community. And they're a great way to gauge overall service delivery. And that may be one thing to add into the pot. I'll be quiet now. Thanks.
Thanks, Kevin. And this is Bruno. There's a lot of support in the chat as well. If you want to drop your eyes, then even an invitation that the Mavericks of Department of Health maybe need to get together with you and strategize and get some support going. Madeleine, I'll give you the last comment or question, and then we need to move on to our next speaker.
Thank you very much. It's around advocacy and organization. I'm very passionate about advocacy. And one of the things I think we all remember is the HIV denialism era. And one of the big responses to that was community-based organization. So I think at the moment what's happening is a lot of advocacy is happening by people working in the transgender space, especially NGOs. And there's lots of other agendas and people you may say upset and not upset and who you can talk to, and people are busy, and you've got CDC requirements and things you have to tick. And how do we organize community mobilization? So we've had a challenge in East London with this very thing. I'm my own particular school, my eldest is non-binary, and we were trying to look at how do we talk for these communities. And your challenge is there's not huge numbers, and it's not assuming that every transgender person is also going to be a vocal, extroverted advocate. Some people just want to literally just leave their lives and get on with things. So what we've done in East London, and this is a very recent new thing, is we've set up a Gender and Sexualities Alliance that's open to anybody, doesn't matter what your sexuality or gender orientation. And we're using that as a community-based organization. We're going to we've started creating some great queer safe spaces for socializing and interacting, but that gives us a voice. So when you go to a school or when you go to a clinic or when you go to FRARE or any of these facilities, you're suddenly talking as an organization, and we're pulling in all the amazing work being done by NGOs like Wits RHI and She and Beyond Zero and FBD in the area, and looking at how we create a community voice that's not just coming from organizations, but actually coming from the patients and representing those patients. Because patients on their own don't feel like they've got any power, and they don't feel like their little letter is going to make a difference. So it's a little bit about perhaps how we start organizing on a community level and pull it all together into one voice.
Thanks, Madeleine.